Hello, I'm Louisa Ells. I'm a professor of obesity at Leeds Beckett University and principal investigator for the remission study, which I would like to introduce you to in this presentation. So, the remission study is an NIHR funded evaluation of the NHS low calorie diet programme. So, I thought I'd start by giving you a little bit of background to the low calorie diet programme. As we all know, type 2 diabetes prevalence is increasing and poses a major risk to population well-being and the sustainability of the NHS. Therefore, the NHS long-term plan back in 2019 announced that a low-calorie diet will be piloted at scale from 2020, informed by evidence from the direct and droplet randomized control trials. The resulting NHS low calorie diet programme is a joint initiative between NHS England, Public Health England, and Diabetes UK. So, how does this programme work? Well, for individuals residing within one of the 10 pilot areas who are aged between 18 and 65 years with a recent diagnosis of type 2 diabetes and a BMI of over 27 or 25 for people of Black, Asian, and minority ethnic origin, can be referred to the programme from primary care following an initial assessment of eligibility criteria and a medication review. The provider will then make contact within the first 5 days and will book an initial assessment within 30 days of the initial contact. After which the programme begins with 12 weeks where all meals will be replaced by total diet replacement products such as soups, shakes, and bars, in addition to a minimum of 8 behaviour change support sessions. This is then followed by a stepped reintroduction to food for the following 4 to 6 weeks, which includes a minimum of 4 behaviour change support sessions, after which participants enter a maintenance phase where they are supported to maintain healthy weight through a minimum of 8 behaviour change sessions for the remainder of the year. However, it's important to note that the NHS is also keen to examine the impact of different behaviour change delivery models, with each area allocated either to group, one-to-one or digital support, with the overarching aim to reduce weight and medication use, improve glycemic control, and achieve diabetic remission wherever possible. So we were extremely privileged to have been granted this NIHR award to undertake a qualitative and economic evaluation of the NHS low calorie diet programme. However, as you could imagine, for an evaluation of this size, it requires a substantial multidisciplinary team, and we have been fortunate to bring together a fantastic collaboration of colleagues from across Leeds Beckett University, in addition to colleagues from across the universities of Leeds, York, Teesside, Lancaster, and Sheffield Hallam, with some fantastic governance and advice provided both from our formal NIHR project oversight group, the NHS England Low Calorie Diet Advisory Group, and a fantastic informal support from our project steering group. However, I can't talk about our project team without giving a huge shout out to our truly amazing patient group who represents lived experiences of obesity and or type 2 diabetes from a range of different backgrounds. And this group have been absolutely fundamental in working with us at every stage from the very start to create a truly person-centered evaluation. Not only were this group critical in co-developing our initial study protocol, but they have also co-developed the study website, all of our patient-facing materials, and they are also being trained to undertake participant interviews. They are producing our lay summaries, blogs, podcasts, and patient films, as well as co-presenting with us and co-authoring all of our study documentation, so that people living with diabetes and excess weight are central to everything we do. So the aim of this evaluation is to deliver a co-produced, comprehensive, qualitative and economic evaluation of the low-calorie diet pilot that will be integrated with the NHS quantitative analyses in order to provide an enhanced understanding of the long-term cost effectiveness of the programme and its implementation, equity and transferability across broad and diverse populations. So this study aim will be achieved through a number of different objectives, which will be delivered through 5 interlinked work packages. So the first of our objectives is to assess different providers' experiences of the programme, including any barriers and facilitators to implementation across different populations. Our second objective is to assess the experiences and attitudes of NHS healthcare professionals involved in supporting patients and those hosting the intervention. We're also interested in gathering their opinions on the management of patient referrals. Our third objective is to assess patients' experiences of the programme, including patients from a range of different socio-demographics and different engagement experiences within each of the different delivery models. This is to gain insight into what worked, what didn't work, for whom, why, and how the programme could be improved in the future. Our fourth aim is to estimate the long-term effectiveness of each of the different delivery models in terms of cost per quality adjusted life year. This will include undertaking a cost analysis of each of the different delivery models to enable comparisons with other demands on healthcare resources and also to support commissioning decisions. Our fifth objective is to assess national rollout of the programme through a comprehensive transferability and programme impact assessment. And then finally, we will integrate the findings from this work with the quantitative analyses conducted by NHS England in order to examine whether the outcomes of the droplet and direct trial can be replicated within larger and more broad and diverse populations and with different providers and different behaviour change delivery models. We will also use this combined analysis to examine how the results of our programme could impact on published cost effectiveness estimates from the direct trial and support future commissioning, and also to provide a comprehensive understanding of the programme implementation and impact by socio-demographics, delivery model and locality, examining patterns and trends to inform future service development and commissioning. And finally, we will determine the transferability and policy impact of the programme. So the first of our delivery work packages is Work Package 1, which is very much concerned with the overarching project management, really taking a focus on the co-production elements, the patient involvement and the dissemination of our findings. So our second work package is very much focused around examining service delivery and fidelity, and will address our first 4 research questions. So these are: what are the theoretical principles, behaviour change components, content and mode of delivery of the programme, and how do these vary across the sites and providers? We also want to understand to what extent does the staff training delivered by each provider address behaviour change theory and content, and how again does this vary across the different sites and providers. We'd also like to ask to what extent is the delivery of the NHS low calorie diet programme delivered with fidelity to the specification as set out by NHS England. And we finally would like to ask, what are provider and NHS support staff experiences of the service, and what do they perceive to be the key barriers and facilitators to effective delivery, integration and normalisation into routine care? So we'll be taking very much a mixed methods approach to address these 4 research questions. And these methods will include a documentary review to collate service details and wider service support information, such as local care pathways, local prospectuses, services linked to the programme. We'll also examine the impact of COVID-19. We'll look at mobilisation plans, referral logistics, training, communications, and individual programme characteristics, which will be collected via the Starlight survey. In addition to this, we'll also be undertaking 90 session observations to check fidelity across the different delivery models and across the 3 different phases of the programme. We'll also undertake 40 semi-structured interviews with NHS staff involved in the referral, clinical care and local programme coordination, in addition to 10 focus groups with each of the different service providers. So work package 3 is very much orientated around examining participant experience and inequalities, and it will address the next 4 research questions, which are to ask to what extent is the content of the NHS low calorie diet programme understood and applied by its participants? Do socio-demographic characteristics influence access, uptake, compliance and success on the programme? And does this vary across the different behaviour change delivery models? What aspects of the programme work? don't work, for whom, why, and within what context? And if effective, how can the programme be improved in the future to enhance participant experience and ensure any inequities are addressed? So again, we'll be taking very much a mixed methods approach to this, and these methods will include longitudinal and cross-sectional participant surveys. These will be undertaken at baseline and then again at the end of the 12, 18 and 52-week periods to capture experiences on the total diet replacement, the food reintroduction and the maintenance phase of the programme. And this data will be linked to the minimum data set that's currently being collected by NHS England. We also aim to undertake around 30 to 60 longitudinal participant interviews, which will include an optional 24-hour food recall and the use of visually represented participant journeys using an adapted photo voice methodology. And these will be undertaken at 12, 18 and 52 weeks. And we aim to use a maximum variation sampling in order to gain insights from a diverse cross-section of participants from each of the different delivery models, including around 6 to 10 interviews with participants who have withdrawn from the programme at some point. Finally, what we will hope to do is triangulate these qualitative insights with the quantitative outputs with NHS England, which we hope to occur on a quarterly basis. And I guess what's important to note here is we've really worked closely with our patient group to really try and ensure that the study in itself isn't introducing any inequities. So we've ensured that there are free phone numbers, we've ensured that there are translators available, and we are working with researchers from our different diverse target community groups in order to help facilitate the widest possible participation. Work Programme 4 is our economic evaluation, and this is led by Adam Martin at the University of Leeds and will address the next 4 research questions in this study, which are to ask what are the costs of delivering the NHS low-calorie diet programme from an NHS perspective, and how do they differ across the different behaviour change delivery models, and also in order to be able to compare these estimates to those provided within the droplet and direct trials. We also want to know what are the costs of the programme to participants and how do they differ by different delivery models and different socio-demographics. We also want to know what is the long-term cost effectiveness of the programme in terms of cost per QALY, and how does this vary by different delivery models and different participant characteristics. And finally, we want to ask how does the cost and short-term outcome data collected in this study affect the estimates of previously published cost effectiveness data. So again, we'll use a range of different methodologies, which will include participant and healthcare system cost analysis, participant level simulation modelling to estimate the long-term cost effectiveness of each delivery model in terms of quality adjusted life year. And we'll also be undertaking an economic analysis using methods used within the droplet and direct trials. So our final work package 5, is the transferability assessment, and this will be undertaken by Dr. Maria Bryant at the University of York and will address the final research questions in this study. So these are, what are the core elements of the intervention that are required to achieve impact? What elements can be adapted to suit local context? And what are the policy implications for widespread adoption of the programme? So these questions will be addressed using a transferability conceptual model, which will be informed by a range of different data sources, which will include documentary reviews, population reviews of national databases. We'll combine evidence and data from work packages 2 and 3. We'll be undertaking some rapid reviews, some short Qualtrics surveys in non-pilot areas in order to capture transfer methods such as goals, structure management, expectations, relationship building, information exchange, support and needs for training. And then finally, we'll host 2 national workshops with commissioners, policymakers, service providers and participants to explore the transferability using data gathered from this work package comparing and contrasting the primary and target context to really try and get a better understanding of the steps needed to ensure optimal transferability. So in terms of data collection, this study started back in October last year and is a 3-year programme of work completing at the end of October 23. However, what we're hoping to do as data collection begins, with most of our primary data collection starting in June, we'll be providing regular interim updates to ensure that data collection informs sort of shared learning and development of the programme as we go forward. So in terms of our progress to date, our ethical approvals are progressing well and should be in place for our June data collection start. Our participant surveys have been comprehensively tested with a socio-demographically diverse range of current service users from each of the different delivery models to ensure they are usable and fit for purpose. As I mentioned previously, the documentary review data collection is in progress and analysis is underway. The Starlight surveys have been completed by each of the different service providers and are currently being analysed. We've also recruited 2 PhD students who will be supporting this evaluation programme through their research programmes. The remission website and branding have been developed. We've been working with our patient group to develop some podcasts and blogs, which will be appearing on our website very soon. We are also just in the process of developing a participant film with our patient group to provide some background information about the study for the survey and interview data collection. And we've also registered the study and published our protocol on the NHS website, as well as continuing to work in close co-production with NHS England colleagues and the Low Calorie Diet Advisory Group in order to ensure we're providing an agile evaluation that is responsive to need. So that is it. I would like to say thank you very much, and also to acknowledge the NIHR for funding this work. If you have any questions, please don't hesitate to email me. Thank you again.